Hello, my name is Paul Mayo, MD. I work over at Long Island Jewish Medical Center in the New York City area, and I've been asked to talk a little bit today about critical care ultrasonography in the context of giving I guess it's called a virtual grand rounds to Cleveland Clinic. Just as an aside, I have to give a call out to two colleagues of mine at the Cleveland Clinic. Dr. Ajit Moldhekar is a very, very proficient critical care ultrasonography person who works over in the NICU. So if any of the audience really want to know something about the field, be sure that you contact him. And then Dr. Hatta's group on the critical care anesthesiology side, they're deeply involved with critical care ultrasound. They're bringing it on heavily in their fellowship training program. So that's another group that's really doing very good work with critical care ultrasonography. So in a sense, I think I'm sort of bringing coals to Newcastle in this discussion, but I'll give you a quick review of the field, both maybe to so people can learn something about it, but also to motivate those who are interested in pursuing training. You might ask, what is critical care ultrasonography and why to do it? Well, the definition is simple. It's any component of ultrasonography that's relevant to critical care medicine. Why to do it? Well, first of all, ultrasonography is a completely mature imaging modality. It's been validated for decades by the radiology and cardiology community. It doesn't need to be proven that it works. So it's fully validated. It's already in use in a lot of ICUs all over the world, and it's really become much more accessible, say, in the last 10 years because small, high-quality ultrasound machines are now widely available, both here and abroad. And a few other reasons why. Once more, I want to emphasize that in Europe, in Asia, Australia, it's used very, very commonly in ICUs, and these are really excellent critical care groups. So that's reassuring as to why. Of course, it gives you immediate diagnostic information. You guide all sorts of ICU procedures. It can be learned relatively quickly, and by replacing other image modalities, especially CT scan, you have major cost advantage. In addition, by doing point-of-care scanning, the cardiology and radiology services are no longer overburdened by having to send personnel into the ICUs. That's a cost advantage. And the other major advantage as to, well, why to do it is that it really reduces radiation exposure when it comes to CAT scans. I'm going to argue a little bit later in the presentation that particularly for chest CAT scans, critical care lung ultrasonography can largely replace those in the ICU. In essence, then, why to use it? Well, it's really an extension of standard bedside assessment methods, sort of like an extension of physical exam. Who, when, and where? Well, I would say all interested pulmonary critical care medicine clinicians. And I specify clinician because certainly in the New York City area, more and more NPs and PAs are starting to man the front lines in our ICUs, and I've had a large number of them come through some of the big national courses, and they become very proficient scanners. So it's not only physicians, it's for all frontliners. But it's particularly well designed for what I would call full-time bedside intensivists, not the consultant who comes in for 15 minutes every day and sort of does a quick analysis of the case, but it's really designed for people who live at the bedside in the critical care environment, in the trenches, so to speak, the real frontliners. And when is it deployed? Well, that's simple, immediately, repeatedly, and whenever indicated. In the ICU, in the procedure room, for floor consults, RRT calls, things like that. The machines are small, portable. Any place a patient is critically ill is where it's deployed. And the basic principles of the field are pretty straightforward. The examination is performed by the clinician at the bedside of the patient. It's not performed by a technician or a consultative cardiologist or radiologist. It's performed by the person who's in charge of the case. The examination is immediately interpreted by the clinician at the bedside of the patient, and the results are immediately applied at the bedside of the patient. And the examination may be limited in scope, can be very comprehensive in scope, and it's repeated as often as is required. This gets rid of some of the problems with standard ultrasonography, where if a team needs to rely on, even well-organized radiology and cardiology services, there's always a time delay between when you want the examination and when it's actually performed. In the United States, most ultrasonography in ICUs is still performed by very capable ultrasound technicians. Then they have to bring their results to a person who actually interprets it. There's always a delay there in getting the result. Then the report has to be issued. It has to be then finally gotten back to the ICU team. And one of the clear rules of critical care management is that a person is very, very sick. You need to have immediate information. There's also a problem that with what I would call clinical dissociation, where the person who's interpreting ultrasonography offline in a delayed fashion never really knows the details of the cases. They'll have a scribbled little description of the case on the order sheet, and they're not really knowledgeable about really what's going on, and they're not directly involved. They don't have a heavy stake in the case. Radiology and cardiology services are really not organized to do repeated goal-directed examinations. Say a patient comes in and they're in a profound shock state with severe LV dysfunction. Is it feasible for the cardiology service to image that heart once dobutamine has been started, to come back half an hour later to see if it's effective, it's actually doing something, and then to come back several hours later to see if the patient is preload sensitive or not? And then the radiology service will need to come several times a day to image lung ultrasound, to rule out pneumothorax following procedures very rapidly. It's simply impractical. It's best done by the people who live in the ICU. And in general, radiology and cardiology, I think for good reason, they're not interested in performing what I would call really limited, focused examinations. They much prefer, for practical, I think maybe even for medical, legal reasons, economic reasons, to do a full examination. Once done, it's very hard for them to provide repeated service on that patient. In trying to decide what the intensivist should know to be competent in critical care ultrasound, I would recommend this document here. The ACCP and the big French Critical Care Society a number of years ago put together a very definitive, simple statement of what constitutes competence. It encourages what I term a modular approach, where there are several very distinct parts of critical care ultrasonography, and it really will offer you a roadmap of what needs to be known in terms of becoming competent in the field. So I'd recommend that as a read for those interested in pursuing training. The first module is the one which we all use. Ultrasound guidance of vascular access. Well, it answers the question, why not identify the target vessel with ultrasonography instead of using landmark technique? Why not look where to go as opposed to guess where to go? The evidence is clear, it's unequivocal. For the IJ position, ultrasound increases success and reduces complication rate. Subclavian position as well. Femoral position the same. For peripheral venous access, many of our patients have vessels that simply cannot be identified by palpation or by visual examination, and therefore they're very, very difficult peripheral venous access challenges. And with ultrasonography, it's been demonstrated in a number of EM studies in particular that ultrasound for peripheral venous access really, really increases success rate and reduces the number of passes that are required. Arterial access, the same holds. If you could see the vessel under ultrasound, your chance of getting into it with minimal number of attempts is greatly increased with ultrasound for arterial, for venous, for all these things. Now, in doing IJ and subclavian access, it's not just a matter of identifying the vessel and guiding the needle tip into the vessel under real-time visualization, but rather to maximize utility, what I'll suggest is that the examiner always starts by ruling out pneumothorax. Then, before the patient is draped, both sides should be examined to identify best target site. One side might be better than the other, but also that preliminary examination includes compression study to rule out a thrombus that might contraindicate insertion on one side. So after the preliminary scan is done, the side has been determined which to use, then the usual clap prevention protocol is undertaken. Patient is draped, prepped, everyone's gowned up, etc. And then the needle is inserted under direct guidance into the vessel with ultrasonography. Before dilation of the vessel, it's best to document the wire is in the vein. The reason being that it just improves safety. Dilation of a carotid artery inadvertently is a major issue, whereas if it's an inadvertent simple needle stick, generally that won't be a major safety risk. So always I would recommend document the wires in the vein before dilation. And finally, rule out pneumothorax when the procedure is over immediately. And in fact, detection of pneumothorax is so effective with ultrasound that for that purpose, a follow-up chest X-ray is simply not required. We'll talk a little bit about that later in the presentation. Here I've projected two images. All of you who do ultrasound guidance of central venous access will recognize that on the left-hand side, we have a IJ, which is positioned lateral to the carotid, which is normal variant anatomy. About 5% of normal patients will have variant anatomy. For example, on the right hand, we have a large IJ, which is anterior to the carotid. This is an invitation to perform an inadvertent arterial blood gas. This variant, which is not uncommon, is not detectable through physical exam, and these two side-by-side images tells you exactly why ultrasound is mandatory for guidance of central venous access. There are other variants where the carotid will be completely lateral to the vein, or there's such a thing as a disappearing IJ, where the IJ will simply be the size of 1 or 2 millimeters. And ultrasonography identifies these variants so that a separate site can be selected for much greater safety. So I think guidance of venous access is very straightforward, completely supported by evidence, is now industry standard on the critical care side. A related module of critical care ultrasound is diagnostic vascular ultrasonography for DVT, It answers the question, why not determine whether the patient has a DVT yourself? Some hospitals can provide very rapid DVT study at any time, day or night. Cleveland Clinic may be one of those hospitals. But in the New York City area, when we studied this, we found that in 3 of the major tertiaries in the hospital, there was up to 36-hour delay in obtaining a DVT study in the ICU. I repeat, 36 hours. This is completely unacceptable. And therefore, as intensivists, we can answer the question ourselves with an examination that takes literally just a few minutes to perform at point of care. If the vessel of interest is imaged in 2-dimensional imaging, a visible clot within the vessel is obviously diagnostic. Fresh clots tend to be relatively or even completely anechoic, so lack of compressibility of a vein is diagnostic of a DVT, whereas full compressibility is strong evidence for lack of DVT. And what's interesting is no Doppler component for the study is required. That's been well validated in multiple EM studies. Doppler offers nothing in terms of advantage to a well-performed compression study. And there's strong literature to support the concept that emergency medicine and critical care medicine clinicians can perform very accurate DVT study at point of care. The entire examination can be performed in less than 5 minutes, with skill less than 3 minutes. And I'll refer you to a recent publication by Corey et al., which demonstrates that intensivists, critical care physicians, can perform high-quality DVT exams when compared to the results of standard vascular examination. In the patient with acute dyspnea presentation or acute hypotensive presentation, obviously, knowledge of whether a DVT is present is very important information that can either make a diagnosis or can guide the clinician away from diagnosis. Here's an example of a video clip showing the common femoral vein with the saphenous coming in from the side. I see a little flicker of a valve movement, and I see a echogenic mass within the vessel lumen. This is what a visible thrombus looks like. Compression is not required. And in fact, it might be contraindicated to do too forceful or repeated compression for fear of dislodging this thrombus. This is diagnostic. And again, a clinician with a little bit of training can perform this at any hour, day or night, in the critically ill patient if they have concern or want to rule out DVT. This can have major clinical implication in the management of the patient, obviously. The next module would be thoracic ultrasonography, divided into pleural and lung. And pleural ultrasonography is as straightforward as vascular access ultrasonography. Pleural fluid is identified very easily. It can be quantified, and it can be characterized. And then obvious, once identified, ultrasonography can be used to guide safe thoracentesis. In examining a patient for pleural effusion, there are 3 cardinal features that the intensivist would require. The first is identification of an echo-free space that represents, or a relatively hypoechoic space that represents the pleural effusion. This is not sufficient because the intensivist must then define typical anatomic boundaries that surround the effusion in order to call it an effusion. And finally, the intensivist will seek to identify typical dynamic changes that are characteristic of pleural effusion. I'll emphasize these 3 features because the careful ultrasonographer will always want to identify all 3 to be absolutely sure that thoracentesis is safe. In the left-hand video, we have a echo-free effusion. I can see the relatively hypoechoic, in this case, echo-free space. That's the black areas. Then I ask, are there typical anatomic boundaries? I see the curvature of the diaphragm. I see the inside of the chest wall. I see the surface of the lung. The audience will notice, of course, that the lung, the lower lobe of the lung, is miniaturized. It's small. It's airless. It has a pattern that is termed technically alveolar consolidation. But the alveolar consolidation is not from a pneumonia, it's from compressive atelectasis. So we have the echo-free space subtended by typical anatomic boundaries, but we also have typical dynamic findings, movement of the lung, cardiophasic, and movement of the diaphragm. Beneath the diaphragm, of course, is a collection of ascites. That's why the diaphragm is so well outlined. And for more advanced ultrasonographers, the liver has it's somewhat heterogeneous, and in fact, that represents a hepatic mass, that area that's a little bit more echogenic. On the other hand, when you're examining for pleural effusion, instead of having a echo-free space, which is characteristic but not diagnostic of a transudative process, you can observe complexity, severe complexity in this case, within the pleural effusion, multiseptated with hypoechoic, heterogeneous hypoechogenicity within the septated collections. I see the diaphragm over to the right, the underside of the lung on the left, the inside of the chest wall. I see dynamic findings. So even though there's complexity, I still seek the three rules: a relatively hypoechoic space, typical anatomic boundaries, and dynamic findings. Both of these pleural effusions would be amenable to thoracentesis, although obviously the effusion on the right might require either VATS intervention or a chest drainage device with thrombolytic therapy. Lung ultrasonography is a very interesting application of critical care ultrasonography because it can identify pneumothorax, lung consolidation, interstitial or alveolar syndromes, a normal aeration pattern, and obviously pleural effusion. And those are the patterns of disease that we really are interested in critical care practice. Where lung ultrasonography fails, it's not able to image mediastinal structures very effectively. And also, air within the lung itself blocks further transmission of ultrasound so that smaller lesions, a solitary pulmonary nodule that's completely surrounded by aerated lung, will be invisible. But that type of pathology is not of great concern to the critical care specialist, whereas the ones I've listed here really are. Lung ultrasonography is superior to standard supine chest x-rays in the ICU, and it's actually quite competitive with CAT scans in terms of identification of these abnormalities. It has immediate bedside application, can be done anytime, very quickly, and with goal-directed intent. So, it's superior to portable chest x-rays for the things that we're interested in: identification of normal aeration pattern, alveolar interstitial pattern, consolidation, pleural effusion, and, by the way, pneumothorax. Just flat out, there's simply no comparison necessary. Lung ultrasonography is so far superior. What's interesting is an article by Lichtenstein that's been confirmed in recent years by a Greek group, that lung ultrasound is pretty much similar in performance characteristic for these indications: pneumothorax, normal aeration pattern, alveolar interstitial pattern, consolidation, pleural effusion, as is chest CT scan. In my ICU, we perform very, very, very few chest CT scans for the reason that we rely on ultrasonography for that purpose. In fact, Zanobetti et al. Is ready to declare the death of the chest X-ray in the emergency department by implication in the ICU. Very nice article in Chest. And a very thoughtful article by Eric Maury in France describes how to integrate ultrasonography into unit operation in order to reduce number of standard chest films. So it really has major application at the bedside to clarify the ambiguous chest radiograph. I think we all agree that the inadequately penetrated or over-penetrated, rotated, supine chest films that we see every morning, they really are quite confusing. They have an element of summation artifact, ambiguous radiodensity pattern, and therefore the solution to this problem is to simply no longer order them, except for very specific indication, and instead to use ultrasonography in their stead. In my ICU, we no longer do daily mandatory chest films on patients on ventilators. Instead, we rely on ultrasound. If we have a patient with acute decompensation on a ventilator, for example, we rely on ultrasonography. So it's a really powerful technique for clarifying and therefore getting rid of the ambiguous chest radiograph. Just take out the transducer. Lichtenstein has published a nice article on the application of lung ultrasonography for rapid evaluation of acute dyspnea. He has an algorithm that can be adapted to your use. Sort of related issue is you can distinguish between something called A lines and B lines in lung ultrasonography, and they have a strong correlation with the pulmonary occlusion pressure. If the A-line pattern is predominant in the anterior lung zones in a patient with acute dyspnea, you can turn to your colleague and say the POP is less than 18 and probably less than 12, just by that 10 seconds of examination. No PA catheter is required in that patient. And in that moment, cardiogenic pulmonary edema has been excluded from the differential. Taking that a step further, Copetti et al. Have written a very interesting article to distinguish, using ultrasonography to distinguish cardiogenic pulmonary edema from acute respiratory distress or primary lung injury pattern. So we know that A-line predominance in acute dyspnea presentation rules out parenchymal lung disease or interstitial lung disease of any type right away, causing the dyspnea. But for the patients who have B-line predominance, there's always the question is, do they have primary lung injury B-lines or do they have CHF B-lines? And he's described that focal B-lines with irregular pleural line is strongly indicative of primary lung disease, whereas profuse B-lines with smooth pleural line is very, very characteristic of CHF B-line pattern. Some other interesting applications to think about would be the big French group Jean-Jacques Rouby has published using lung ultrasonography to assess PEEP-induced lung recruitment. Also, the same group were able to track resolution of ventilator-associated pneumonia with lung ultrasonography, as well as being able to predict extubation failure during spontaneous breathing trial with lung ultrasound. Some of the German groups are very interested in using lung ultrasonography for diagnosis of pulmonary embolism. This article is worth a read, but they agree that it's not yet, a perfect test at all, but their research is quite interesting. So those are some more advanced applications. The next module to talk about would be goal-directed abdominal ultrasound. And unlike lung ultrasonography, which I believe can largely supplant chest CT, it's very obvious that abdominal CAT scan will always be the best modality for precise imaging of abdominal content as well as the retroperitoneum. However, abdominal ultrasonography has some application for the critical care clinician. One of the problems with abdominal ultrasonography, unlike lung, which is fairly straightforward in terms of the learning curve, is that abdominal ultrasonography is very, very complex. To become expert level requires a very long period of training, similar to what the radiologists go through. However, there are certain applications that can be learned quite easily, as well as they have immediate clinical application. I'll include in this list identification of intra-abdominal fluid, ascites, perhaps to rule out free air and to rule out peritonitis ischemic bowel, to identify a AAA, and any patient with renal failure, new onset renal failure. It's obvious that hydronephrosis has to be excluded, as well as the simplest form of anuric renal failure, which is a Foley block in the ICU. And then generally the intensivist needs to have some sense of what organs look like and whether there's gross abnormality. But I would discourage really much more than what I've listed here, simply because CAT scan is so much more effective, although somewhat less practical, as well as it's very hard to learn stuff that's more complicated for abdominal application. Intra-abdominal fluid is very easy to identify. We're not talking about surgical applications or trauma applications, but just as an aside, the so-called FAST exam, focused assessment sonographic of trauma, includes with the rapid evaluation or intra-abdominal fluid collection in the trauma victim, particularly with abdominal trauma. But for medical applications, generally we're looking for whether there's fluid, how much there is, to characterize it, and also to see if there's a safe window for paracentesis. For example, in left-hand image we have anechoic ascites. That's the black there on the screen, that nicely outlines a number of loops of bowel. I do notice that the bowel wall thickness is abnormal, suggesting there might be a bowel process. But the main thing is this would be an excellent window for safe paracentesis. Although not diagnostic, the nature of the fluid, which is entirely echo-free, suggests it's probably going to be a transudate. On the other hand, we have an acutely decompensated patient in a severe shock state, and the abdominal ultrasound at a screening level identifies the liver surrounded by ascites, which has major complexity to it. This patient had a acute perforation of diverticular structure, and she had soiled her peritoneum with feces. Very easily, the patient had a paracentesis, and the diagnosis was made very promptly on that basis. Here, a patient who has acute or progressive renal failure. The most common cause for anuric renal failure is that the Foley is simply not working. So over on the left side, we have the Foley balloon inserted within the bladder, and the nursing staff reported the patient has acute anuric renal failure. In a few moments, we were able to sort that out by a quick suprapubic exam, and the Foley was flushed, and we called the renal consult back saying we didn't need them today. On the other hand, we see in the right-hand image severe hydronephrosis, and in the patient with renal failure, this would be a major finding that would require prompt response. Those are two examples of the simplicity of performance as well as the type of things that you find if you do screening, GU, ultrasonography, and ICU. I've elected not to show too much abdominal ultrasound abnormality, but rather to turn to screening echocardiography. We'll define that as a limited examination to evaluate LV and RV function, LV-RV size, look for tamponade, major valve failure, to look for preload sensitivity. Screening echocardiography can be done immediately and repeatedly. And for those who doubt its acceptance, I'll refer you to a recent document written by or endorsed by the American Society of Echocardiography, which fully supports the concept that EM people and therefore critical care people can and should perform screening echocardiography. There are many sort of minor variants of screening echocardiography or basic echocardiography. Some people call it goal-directed. A lot of acronyms, Focus Plus, things like that. We'll just call it screening or basic critical care echo. And one approach is to say there are 5 standard views that are mandatory in a rapid assessment of hemodynamic failure in the critically ill: parasternal long and short, apical 4, the subcostal long view, and IVC long axis view. Just 5. I'll remind you that advanced critical care echo would require a very, very high level of training, similar to that required for cardiologists. It would involve full training in all aspects of Doppler and the many, many other standard views. So we're not talking about that at all. We're talking about rapid assessment of cardiac function with these 5 standard views. The question is, why should an intensivist know how to do this? Well, the reason to do it is to identify immediately life-threatening causes for shock, to categorize shock state in order to guide management plan, to observe the effect of management, to observe for progression or regression of disease, but also to identify coexisting conditions, particularly in older patients who may have septic shock and, for example, tight AS. That greatly complicates management strategy in that population. So, for example, in the right-hand screen, we see a good quality parasternal long performed by a fellow with minimal training. Overall LV function is normal. The RVOT is not dilated. Left atrium, by qualitative analysis, we're not doing advanced echo, is enlarged. I see a pleural effusion with some atelectatic lung within it. See the ascending aorta, but the mitral valve has a Flail Leaflet. This patient was gravely hypotensive, had fulminant, life-threatening MR, pulmonary edema, and hemodynamic failure. And this type of situation cannot wait for a full-scale echo. Some hospitals might be able to provide that service, but most cannot. This is a visual diagnosis done by a first-year fellow. The cardiac surgery team is called immediately. The aortic balloon goes in, and they're prepped for surgery. The patient's life is saved because there was no delay in diagnosis. Likewise, in the left-hand image, we have a dilated apical 4, we have a dilated RV, and a large thrombus in transit in a patient who was gravely hypotensive, who was near death. This is not a diagnosis that can wait for formal echo. This diagnosis can be rendered at bedside with a standard 5-view approach, and immediate action needs to be taken in this patient. There could be no delay. The patient with acute cor pulmonale from pulmonary embolism will present with characteristic features, both in clinical presentation, then confirmed with quick look-see 5 standard view screening echo. I see on the left side a large RV and parasternal short with a D-shaped heart. In the right clinical situation, in this case, the patient had a DVT that was diagnosed immediately at bedside. They received thrombolytics because they were near death from a large saddle pulmonary embolism. A patient's life was saved by immediate echo. Here we have on the right hand an acute hemopericardium in a trauma situation. See the heart rather small due to compression by the large blood clot. And this obviously has immediate management ramification. This patient cannot wait for the formal echo. Then to guide management to categorize shock state, once the immediate life-threatening processes have been ruled out, they're uncommon, but they have to be identified. Then to characterize shock state, screening echo has a lot of application. For example, we have a patient who was uroseptic, gravely hypotensive, already on pressors. And the question then is, what is the mechanism for the shock state? A screening echo identified in parasternal short-axis view severe global LV dysfunction. And in the IVC long-axis view, a dilated IVC that allowed the team to determine that the patient would not benefit from sepsis bundle automatic volume resuscitation. Here, no further volume would be given. And for low flow, this patient needs inotropic support in addition to other vasoactives. So by performing immediate screening echo, the team could characterize shock state and could make very specific recommendations or maneuvers in terms of initial management strategy. I mentioned also the need to follow the patient with repeated scan because critical illness is dynamic in nature. This is the same patient 3 days later who now has normal LV function. This would be typical for sepsis cardiomyopathy. So follow-up screening study is certainly indicated to look for evolution of disease or new problems. And finally, the other reason to do screening echo would be, especially in older patients that I mentioned, the common problem of the patient who has an obvious cause for shock. For example, in this case, they had, again, urosepsis. But they also had, by simple 2D analysis, severe aortic stenosis. So the management team will need to modify their approach in this patient. They also have segmental wall motion abnormality. That is not considered to be a requisite for competence in goal-directed echo or basic critical care echo, but it's quite obvious here as well. So screening echocardiography is a necessary part of the evaluation of every patient with shock. It can be performed in just a few minutes. It is always integrated into the history and the physical and standard lab analysis. It becomes an extension of the physical examination. And I refer you to 2 landmark articles on the subject, one from Volpicelli, and he showed that in patients in what they termed undifferentiated hypotension, meaning shock that did not have an immediate diagnosis like profound bleeding or multiple trauma, stuff like that, more medical shock patients, that his group was able to render diagnosis as to the category of shock 100% of the times with an examination that included screening echo. Their entire exam included both screening echo, lung ultrasound, and DVT study, and it took them 4.9 minutes to perform the examination on average, so it really adds nothing in terms of time of evaluation. but it adds everything in terms of diagnostic value. And Laursen, that's a Scandinavian group, they report similar results. So I'd recommend these two articles to you if you remain unconvinced. In conclusion, I would maintain that ultrasonography has major utility in the ICU. It requires competence in cognitive-based image acquisition, image interpretation. It's performed by the frontline clinician who integrates it into the overall care plan, and it's performed immediately, repeatedly, and in goal-directed fashion. It should therefore be a routine part of ICU care. As an aside, the ACGME, which establishes the standards for fellowship training in critical care and pulmonary critical care medicine, on July 1st, 2012, they mandated that pleural and vascular access ultrasonography was a required part of fellowship training. And now, as of July 1st, 2014, they're mandating that knowledge of ultrasonography is mandatory, meaning that all aspects are mandatory. So the fellowship programs will be introducing it into the training sequence. And for those of you at the clinic who are interested in the field, once again, I'll remind you that you have excellent internal or local resource in the form of Ascites over in the MICU, and also on the anesthesia side with Dr. Hatta's group, both very, very involved with ultrasonography. I'm asked to put together a couple of questions, so I'll give you question one. Which statement is true? Regarding ultrasonography examination for DVT, intensivists cannot perform accurate ultrasonography examination for DVT. Doppler study is needed to perform an accurate DVT study. Visual identification of a thrombus is diagnostic of a DVT. And full compressibility of a vein is diagnostic of a DVT on ultrasonography examination. And three, of course, would be the correct one, that in fact intensivists can perform accurate exams. Doppler is not needed. And if the vessel is fully compressible, it does not have a DVT within it. Which statement is true? Regarding critical care ultrasonography, it must be performed under the supervision of a qualified radiologist or cardiologist. It should not be used for limited or goal-directed type of examinations. It includes training in Doppler-based measurements for intracardiac pressures and flows, and it should be the routine part of the evaluation and management of the critically ill patient. I would vote for number 4 because, in fact, intensivists can perform all aspects of critical care ultrasonography independently of radiology, cardiology services. It can be used in limited goal-directed fashion, and basic echo does not require knowledge of Doppler for its good performance. I want to emphasize that part of training in critical care ultrasonography is that the intensivist has to know their limitations so that our radiology and cardiology colleagues are the true experts. And if there's any question about the quality of the scan or that the question that's asked is not being answered by the scan, then the first thing that I do is I call in my expert colleagues. Which statement is true regarding lung ultrasonography? It's inferior to standard radiography in the ICU. It's similar to chest CT for ICU applications. It's useful to identify solitary pulmonary nodules. It has no utility for the evaluation of acute dyspnea. And number 2 would be correct. Which statement is true regarding basic critical care echocardiography? The ASE is opposed to the concept of non-cardiologists performing the examination. It requires 10 2D views and 2 Doppler measurements. It is useful for rendering diagnosis and guiding management of the patient with hemodynamic failure, and it should be combined with a full cardiology echocardiography examination. And in fact, it's useful for rendering diagnosis and guiding management of the patient with hemodynamic failure. It's fully accepted, endorsed, in fact, by ASE. It's only 5 views, and only if the intensivist feels that the question is not answered would we want to bother our cardiology colleagues to bring their big machine over to the unit. Thanks for your time.